all on this awesome platform, Urology Learning Through Others Experience, where Nitesh Jain and his team working day in, day out since last 2 months in this lockdown period, and probably crossed 150 figures so far, so online or virtual meetings.
Congratulations.
Yeah. And this is the second edition with the Meet the Experts with the Professor Margrit Fisch. And last our session, which was held before 27 days, was very much appreciated. And in continuation, as we promised, this is the second edition of the same Meet the Experts Meet on Pediatric Urology. Today we have a with the Margrit Fisch and Professor Ansari, Professor Hemanth Pathak, who is the head of the Pediatric Urology Department at the Nair Hospital, Mumbai, and teacher of many of the students, many of the urologists in the practicing in the Mumbai. And with that, we have two special guests today. I would like to introduce them in the detail. We have a Professor Jun Oh who joined from the Germany. He's a head of pediatric nephrology, gastroenterology, and the transplant unit in the University Hospital Hamburg, working in the same institute where the Professor Margrit Fisch is work. And we are very much thankful to Professor Margrit Fisch to invite him and to convince him to be part of this webinar. And for that reason, we are also thankful to Professor Margrit Fisch. And Professor Jun, we are welcoming you on this platform. Professor Jun is also currently serves on the board of the Society of Pediatric Nephrology and the European Society of Pediatric Nephrology. He published over 100 peer-reviewed papers and book chapters. So once again, welcome, Professor Jun.
Thank
and
you.
We have a Kalpana K. Patil, popularly known as Kalpana, for me at least. Did her graduation, post-graduation, and MCH in pediatric urology from AMCHI, Mumbai, from Grant Medical College. She is FRCS in surgery and pediatric surgery. She joined Great Ormond Street Hospital for training in pediatric urology for 3 years. And in year 2006, she got a fellow of European Association of European Academy of Pediatric Urology. And presently, she is senior consultant pediatric urologist in London, also serving at the Evelina Children's Hospital, Guy's and St. Thomas NHS Trust. So, welcome, Kalpana. And I think this makes a perfect team for today's webinar. And with that, I'm sharing the screen and bringing the first case in the discussion. So, shall I start?
Yeah.
Okay. So this is the, we start with the posterior wall. And in this particular slide, I have integrated two cases. In the first case, the scenario was much simpler. It was picked up in the late second trimester or initial first part of the third trimester. And sonography was suggestive of a posterior wall-like condition, with other rest of the things were perfectly all right. No oligohydramnios, no severe dilatation of upper tracts, kidneys echogenicity quite normal. And postnatal, this diagnosis was confirmed with the voiding cystoethography, and creatinine was dropped to 0.58, means was 0.58 at the third day of the birth, which was the first creatinine done after the birth. And in a second scenario, I will give you detail little later. But with this, what generally we practice, or I practice in my clinic, is that as we are knowing that this child was picked up antenatally, immediate postnatally, we receive this child generally from the pediatricians or gynecologist in our practice, and then we put the feeding tube, which is a 5 to 6 French feeding tube, and our protocol is to do VCUG either on the first or second day, and generally we hand over this child for looking for these issues of infection, electrolyte and dehydration, possibly because of diuresis. And with that, or second or third day, we generally carry out the lab tests. That is serum biochemistry, renal biochemistry, electrolytes, mainly soda, this bicarbonate, and also relevant other investigations in a first couple of days. So this is the routine our practice. And now I would like to know from the Professor Pathak that, sir, what the protocol you follow in our hospital?
Yeah.
Initial, exactly from where you get the patient. Patient directly come to the pediatric urology department, or you generally get it from the pediatric from the pediatricians, and how
No.
you proceed?
See, there are two setups. One is, in the institute, what happens is when the child has been detected antenatally to have bilateral hydroureter nephrosis, he is closely monitored every 6 weeks for an ultrasound. And as you have mentioned, when there is no, everything is favorable, that is no oligohydramnios. So basically, when the mother is again admitted in labor, the gynecologist alerts the concerned department. And at birth, we do go and have a look and do the labs, an ultrasound, and as you mentioned, a VCUG. And once VCUG is done, after VCUG, we put a feeding tube so that any risk of infection is not there. And if everything is favorable, good, we immediately take the child for the definitive management. So that is the protocol which we follow.
And what is your choice, sir, between the feeding tube or balloon catheter? Which size of
Balloon
feeding tube
catheter,
you choose?
balloon catheters are absolutely out because whatever size you have, the smallest would be 8 French. The the child at birth, yeah, it's even 8 French is a very bigger size catheter. Feeding tube 6 is good enough to drain the bladder, and that is our protocol. Feeding tube is our preference.
Okay. And what about the VCUG? When exactly you do VCUG?
So, we do wait for 48 hours. And once the child is okay, ultrasound is done, labs are done, and then we do a VCUG. There are some uh, pediatric surgeons, my colleagues, what they do is, which we don't follow, we do a VCUG in the radiology suite and take the child. But there are some who would like to do, once their diagnosis more or less is confirmed on ultrasound, they would like to do it on under fluoro and proceed with fulguration at the same time.
No.
But we do
That is,
VCUG.
yeah, that is probably too aggressive. Right.
Yeah.
Agree. And any means this is generally this is just for the interest of the PGs. That do you measure the possible volume and instruct the radiologist not to exceed that volume? How exactly you instruct for that VCUG?
Yeah,
Because
VCUG.
very rarely, but one or two incidents I have seen, even the people have ruptured the bladder uh, doing this VCUG. I have a good picture, but because of time constraint, I have not accommodated that picture. But do you instruct for
See,
the?
basically, the installation is of the contrast is done very gradually, every 10 cc's. Initially, whatever, 20 cc's is put, and thereafter in increments of 5 cc, 10 cc. But it is done under fluoroscopy. So we are closely monitoring.
Perfect.
So it is not that, you like the olden days where you don't have a fluoro. So it is being done under fluoroscopy. So it's a dynamic study which is being done now.
Perfect. And what about the lab investigations? When you recommend serum creatinine, first serum creatinine and electrolytes and
The
count.
standard teaching, if the child is otherwise clinically good at birth, wait for 48 hours, do serum creatinine, send his CBC, urine, and then proceed with VCU.
So, Dr. Ansari, do you want to add anything in this,
Just
Professor?
little difference because whenever the child comes, whether it is a gynecologist or labor room or from the pediatrician, you have to evaluate the ultrasonography yourself. If the upper tract is dilated, the primary intention is to decompress the upper tract. After putting the feeding tube, you are supposed to collect the first drop of the urine whether you subject it to the dipstick or urine culture, because you have to plan the antibiotic as well as for the VCUG next day or day after or 48 hours after that. So we do not hurry for going for VCUG. Our primary aim is to decompress the upper tract.
Perfect.
Bladder is deflated. By the time 48 hours, the urine culture report is also available. Baby is stable, and ESPO also recommends when to do VCUG when the baby is stable, no UTI, no sepsis, no dyselectrolemia, no acidosis.
Right.
Yes.
Right.
How early? It should be done early, agreed, but we should not be too aggressive.
Okay.
And while doing
Okay.
cystogram, I prefer a dip cystogram and voiding film. Drip
Okay,
cystogram, that what the apprehension, what you mentioned is the bladder rupture in neonate. There is a possibility if it is not being done under proper supervision, or the child, the person who is doing, the health personnel who is doing, or a resident who is not being trained how to do it, there is a theoretical risk of damaging the bladder also.
Perfect.
And regarding the investigation, see, we are not interested in getting what is the serum creatinine, because within the first week, this is a maternal week for the baby. It will be the reflection of the mother's creatinine. Especially this is more relevant in the premature babies. So we need to be a little cautious while interpreting the creatinine level in newborns. So we are only interested in knowing the dyselectrolemia and the acidosis.
Yeah.
If it is there, we need to correct it.
Right.
Is that?
So,
And secondly, yes.
So the priority is to first is to confirm the diagnosis in sonography, right?
Yes.
And then put the feeding tube, collect the urine for the culture, and
or you do deep stick, whatever the facility you have.
Yes. I got it. And then you fix the feeding tube. What is your preference, sir? Feeding tube, or you use a 5 or 6 French Foley catheter,
yes,
probably available in some of the centers.
In neonates and the infants, it is always preferred to put a tube which does not have a balloon, because balloon usually obstructs, irritates trigone. So this may, instead of allowing to drain, this may rather become a cause of obstruction.
Yeah. So this thing why I've raised this. I come across in several of discussion, and a few of the urologists having a preference. And what I have noticed, even with the Foley's catheter of even 6 French size, which is available in some of the center, that it can give a trauma just below the meatus, means at the submeatal level, that balloon part, and while putting it and while taking it out. So there is some chances of submeatal trauma and later on stenosis. And some spasm is also possible with the bulb having there in the touching the trabeculate and inflamed trigone. So I think probably we all are agree on the choice of the tube, that is feeding tube, and it should be fixed well. And after once the patient is stabilized, and we'll go for that to Professor June. But before that, Kalpana,
Yes.
I would like to ask you your institutional practice or your practice regarding these 2-3 issues. If you are differing, you can add something.
Yeah, basically, I think we will be guided by managing a baby with PU valves according to the center and location in the world. That's important. So in India, you will manipulate the management based on what is available. So in the UK, we put in preferably a Foley catheter. And because the smaller sizes of Foley catheter relate to the size of the balloon. So a 6 French Foley catheter will not hold 5 ml balloon. So it is proportionate. Second thing is, Foley catheters are now on an audit done in the UK. Manufacturers have started focusing on the collapsed Foley catheter balloon, not giving rise to a wider diameter. By that I mean
that is the concern issue, that this collapsed part of the balloon area, that is probably wider than the what suppose we say 5 or 6 French catheter, but probably at that particular area it is not 5 or 6 French, and that creates some problem in inserting and while taking out after the deflating the balloon. And occasionally, but I have seen, and that submeatal stenosis or trauma is very difficult to treat subsequently.
Yeah, it's very true, but that is being addressed by the Foley manufacturers following an audit by BAPU, which is the British Association of Paediatric Urology. So that's something which is being dealt with. But the most important thing, I've used all catheters through my career in the UK. The most important function of that catheter is to drain the bladder. And if you look at a feeding tube, there are 2 holes at the end. There are very few holes on a feeding tube. Whereas if you take a Wygon feeding tube, you know, the one with slightly softer than the ordinary feeding tube, it has multiple holes at the tip. Being soft, it's not the easiest to manipulate, but that in principle drains very well. And I've seen it for my patients.
Right.
So if you have a preterm baby neonate who needs a catheter, you can even use the fine silky duodenal tubes. So whatever you are able to use, the main principle is to drain the bladder, because we're going to then monitor the creatinine, and I'll come to that later if I'm asked. However, this is not an easy thing because of the high bladder neck. Your catheter manipulations, whether it is a Foley, whether it's a Wygon, or any other feeding tube, the stiffer the catheter, the easier it is for a junior person to enter the bladder. The softer the catheter, you have to manipulate it in a particular way, because otherwise the catheter goes and coils in the posterior urethra and doesn't progress into the bladder because of the high bladder neck.
Yeah. So it is
That's my
guidelines,
thing. And if everything else fails, you put in a suprapubic.
Yeah. Perfect. Before and regarding your voiding cystoscopy, when you do on a first day, second day, or when the patient is stable, absolutely on this part of say dehydration or acidosis, and,
so basically,
and the infection and all those things. Yeah.
Sorry. Basically, these are all, majority of them are prenatally diagnosed. So they've already come to the clinics, are aware of what's going to happen. So the baby is born in a center where usually pediatric urology, nephrology is available. So because we know the prenatal history of this baby, we have catheterized all the babies as they present to us immediately after birth. And we follow a protocol. I won't go into the details of that protocol because it is right from prenatal period to the birth of the baby till we transfer them to an adolescent urologist.
That's why I will request you to focus mainly on that question which I am raising. That what is your timing for voiding cystoscopy in a case which I have displayed, means first case which I have displayed.
Okay,
the patient is perfectly doing well. On third day, the creatinine is 0.58 with the electrolytes normal. There's no acidosis, no septic. So in this sort of child, when you will prefer to do voiding cystoscopy?
If the child is stable.
Yeah, here you have a child who is absolutely stable.
Then we wait for stability and do the cystogram. And I don't allow the trainees to say just voiding cystourethrogram. I make them say literally voiding cystourethrogram under antibiotic cover. My radiologist will not do the cystogram. Yeah. So once a baby is stable, you can do the cystogram under antibiotic cover.
Right. Okay. Perfect. Professor Margrit Fisch, I will come last on these particular two cases because I know that there are many things probably differing. So I will have to give you a little more in that time. I'm going to give time equally to all. Now coming to this point that Professor Jun, we have a baby where we have put the feeding tube. There was a got diuresis, creatinine is 0.58, electrolytes are okay, normal, no acidosis. So what is the trend in your institute? Means the urologist treat or pediatricians treat all these things, or they refer it to the pediatric nephrologist, and pediatric nephrology department take care of all these issues related to the diuresis, infection, electrolyte, dehydration, like that.
Well, actually, the system at our university is like most of the patients are still at the neonatology unit or ward, and we all come as a consulting to the child and give recommendations. And so, excuse me, let's say the organization or taking care, the handling of the electrolyte is done together in a kind of team effort. Blood samples were taken by the neonatologist, and we adjust the medications. And what I like particularly here at our university is that we have this really, let's say, meeting at the bedside with a team of doctors and decide together and have this individual plan. We are not like in the older days where you have a very strict, plan. This is my patient, this is your patients, and I'm responsible. It's a little bit modern style these days, and that's what I really like, particularly working together with Professor Fisch and her team, because that's a pretty straightforward and very easygoing collaboration.
Perfectly all right. See, here in a place like Junagadh, I don't have a liberty of or facility of having a pediatric nephrologist, but we have a good pediatricians. Along with that, we establish a kind of a protocol, and we generally try to adhere as per the patient's condition evolve with the initial days of the treatment. So it is not like that, but in all places in India also, we generally follow a fixed kind of a protocol, depends on the condition of the patient, with the help of either pediatrician or pediatric nephrologist. Professor Ansari, what is your institutional protocol? You involve pediatric nephrologist from the very beginning, or when it required?
Well, on the need basis.
Sir.
Yes. Whenever there is a need, we involve them.
Okay. Okay. So you primarily keep this patient in your department.
Yes. Yes.
And treat these patients, and if required, yes, to involve the pediatric nephrologist for correcting the certain issues.
Yes, sir.
Okay.
Some basic parameters, derangement like acidosis, hypokalemia, hyperkalemia, and this sodium replacement. All of our residents are basically trained to do it, including the pediatric urology fellow. Once we think that we need to involve pediatric nephrologist or nephrologist, because in India, everybody is so loaded with the volume of the patients. So many times everywhere they may not be available, or all the time they may not be. Some basic corrections, most of us are quite capable and comfortable to do it ourselves.
Okay. Okay. So Professor Ansari and Professor Hemanth Pathak, sir, this patient is on third day having a 0.58 creatinine, is clinically stable, not dehydrated, electrolytes normal, not in septic, right? When you would like to go ahead with the valve ablation, or you will still wait for a couple of days? What is your practice? Means you go ahead with the third day, fifth day, seventh day? What, Professor Hemanth Patil? In this particular patient, I have given you a condition where the patient is perfectly all right on third day. Diagnosis is confirmed. Will you go ahead with the valve fulguration, or you still wait? And why? If you wait, why? Sir, your audio, sir.
Once the a child which is stable and has been optimized by putting a catheter, has been evaluated, VCUG has been done. So in short, at the end of 1 week, once things are good, we take the child for fulguration of the valves. I'm talking of the scenario 1 in a child which is stable, yes, with whatever pictures you have given us.
Yes.
As far as the labs are concerned, the condition is concerned. If things are favorable, good, at the end of 1 week, the child is scheduled for fulguration.
So at least you would like to postpone the procedure for a week.
Yeah, I mean, sometimes what happens, the childbirth, by the time the child has been shifted to our ward, it's already day 3, day 4. So okay, normally, it's about a week's time in a good settled child that he comes for.
Professor Ansari, what you will do this third day? Will you intervene on third day, or you will still wait, and why? Why you would like to wait? Suppose
a child who is having a stable clinical condition,
yeah,
that the culture is sterile,
yeah,
no signs of sepsis.
I receive the culture is sterile,
yeah, no acidosis, no dyselectrolemia. Yeah. Then day does not matter.
Okay, perfect. So you may go ahead on third or fourth or fifth day once the child is stable.
Yes. Yes.
Yeah, perfect. So I have a second case here. You see, in that patient, the bladder was badly trabeculated, and this patient first creatinine on the third day was 0.8 milligram, and on 5th day it was 0.12 milligram. Electrolytes are normal, no dehydration was there, but corrected, not in septic condition. So here the question is that how long you will continue with the feeding tube drainage, Professor Ansari, in these patients, because at 5 day it is 1.2, maybe a couple of days more, it can come down to the 1 or around that. But with that, you will go ahead with the procedure and will take out post-procedure feeding tube after a couple of days, or you will continue with the feeding tube drainage, and how long?
Say for 1.2 creatinine is not too bothering. And as far as this systemic acidosis is not there, then the child is not in polyuria, that diuresis is now controlled, and electrolytes are normal, we may go.
Upper tracts are not responding much, and the creatinine is 1.2. That's only
From 1.8, 1.2, you never
1.2
know.
on 5th day.
This
Yeah.
may be it's nada, though it is too early. It usually at 1 week with drainage of catheter or feeding tube, it gives just a trend that the child might respond to lower tract lower tract management.
Right,
So
perfect, sir.
1.8
The question
to
is that
1.2.
how long you will miss at the most, suppose 7 days, 8 days, 10 days, the creatinine is still remain
In
1.2
this case,
around.
I will not wait for very long time.
How long?
If the
How long you
creatinine,
wait?
yes, if it was, I give you logic. If it was more than 2
Yeah.
creatinine, and if there was persistent acidosis, dyselectrolemia, or the child continue to have some episodes of sepsis, then these are the cases where you will wait for 2 to 3 weeks. 7 days usually gives a trend, but here with 1.2 creatinine, it might take some times to establish. You never know, even if you do vesicostomy, then this might not touch under 1 also. So as far as the other parameters are controlled within 2, I prefer to do wall fulguration and observe it.
Okay. Now, Kalpana, you listen the two response, and you have a case 1 where 3rd day patient is completely stable, diagnosed perfectly with the wall. And second case, at the 5th day, the creatinine is 1.2. Otherwise, patient is perfectly all right. So in these two conditions, what is your practice or institutional practice for the taking the patients for wall fulguration? You still wait even the patient is stable, or you delay the procedure, and why?
So can I just ask one question before I answer? I'm out of date with milligram percent creatinine. What is the normal range?
The normal range is our laboratory says 0.5 to 0.7574 something.
Milligram percent. Okay. So basically the way I have worked in a situation as you have presented to me, if the child is stable, our nephrologists are our gatekeepers in many respects because they look after all aspects of the child. So it's a combination of things. The nadir creatinine. So we do creatinines every day. So if 1.2 milligram percent is the nadir creatinine for this baby?
No, we have only 2 in this second case. We have a 2 creatinine, 1.8 and 1.2. 1.2 on 5th day. We do alternate day in my practice. Suppose this is 1.2, I will still continue with the feeding tube drainage and will look after the all parameters and then repeat creatinine after another 2 days. So every alternate day, maybe in these patients, if I wait, I don't know 1.2 or 1, but in this particular scenario, in both these cases, first case, you have a 3rd day, creatinine is 0.58 and patient is completely stable.
Okay. Yeah. So in the first case, I will do the cystoscopic valve ablation. In the second case, I will wait further, do another repeat creatinine.
Perfect.
And if the repeat creatinine is less than 1.2, I will take the child for ablation. If it is not, I'll continue conservative management.
So now the question is that what single probably line answer is that suppose if you have a feeding tube and patient is doing well, but the creatinine is not falling as per the expectation, how long you will wait with the feeding tube?
I will first check mechanically if the feeding tube is working or not. I'll replace the feeding tube or the catheter and then make a decision.
That is addressed.
Oh, that is addressed.
Yeah.
And your question was the creatinine is still 1.2 milligram.
Yeah. So suppose at 7 days it comes to 1.11, still you will wait, and how long you will wait, or you will go ahead with the valve ablation?
I need at least 2 creatinines to tell me that that is not changing, in which case I will then conclude that this is the nadir creatinine and take the child for cystoscopy.
So that is what I'm saying, that will you, suppose if you wait till 8 days, as per your calculation, there will be 5 creatinines or 6 creatinine.
Yeah.
And the last creatinine, nadir creatinine comes to 1 at the, suppose 7th or 8th day. Still you will wait, and how long you will wait, or you will go ahead with the ablation?
I need 2 creatinines more or less similar to qualify this baby's creatinine as reaching nadir value. So whether it comes in 8 days, whether it comes in 10 days, it doesn't matter.
So you will, till that time, you will continue with these feeding tube drainage, or you will change your treatment plan?
No, I'll continue.
My question is that we all put the feeding tube to stabilize the child and having a nadir creatinine. But how long? In few of the conditions, we may not hit the desired nadir creatinine. So to take the patients on valve fulguration or changing the treatment plan, how long we wait with the feeding tube in the place?
Till 2 creatinines are more or less similar. Then I can call that level as the nadir creatinine for this child. And if you look at all the patients in your experience, then it is usually about a week to 10 days when this starts settling, provided the drainage is optimal. Okay, perfect.
So, Professor Margrit Fisch, now coming to you after long discussion, and I have to move from this slide, but we would like to have your comment and your practice or your institutional practice, please. These 2 cases, you have listened the discussion and the questions, so I'm not going to repeat and spoil the time for raising the questions. Hello.
Yes, hello.
Yeah. So
okay, so we have a completely different approach. Can I have the next slide? Because what we do is to do a cystostomy. We don't touch the urethra at all, neither with a feeding tube or at least with a catheter. And this really gives you time, because then you have a sufficient drainage and it's easy to perform your voiding cystogram. Give me the next slide, please. And these are the 2 concepts that you will find worldwide. You all were referring to primarily valve resection. We do the step-by-step procedure. That means we leave the child with cystostomy. Professor O is taking care of it, and we have all the time in the world, and we do the valve resection at the age of 6 months. Why we are doing it? I'm also an adult urologist, as you may know, and we do more than 300 urethral reconstructions in adult patients. And what we see is that the number of iatrogenic strictures is increasing. So we have now 40% of iatrogenic strictures. And I have seen a couple of children after primarily laser ablation who develop a bulbar stricture. Can I have the next one, please? Yeah. And what you clearly can see here, and this is one of the cases on the left side, if you try to fix that by open surgery, the results are really, really worse. You have this anatomy, which is different. You see the small, tiny corpus spongiosum when you compare it to an adult patient on the right side. So that is at least my argument to say, I do it at the age of 6 months. We have, of course, the facilities in Germany to keep care of the children. Parents are taking care also of the cystostomy. And then I can use a 10 French instrument, and I have a beautiful view, and I don't do any harm to the urethra. And that's the argument for a completely different approach.
Okay. So what I now listening is that you generally prefer to do cystostomy in almost all patients. How exactly you do cystostomy? It is something like what we do vesicostomy, or it is something different? Cystostomy is different. How exactly you do cystostomy? Means so open cystostomy,
please
or
go back. please go back to the other slide. Yeah, you see here the cystostomy in a newborn. It's a very small pediatric cystostomy. It's available on the market, and especially in the valve patient, it's very easy to put it in. It's just a puncture. It's much easier than to put any feeding tube in, and even a first-year resident could do it. Professor O will yeah,
you
he's
take it
shaking,
out
so
after,
he's supporting me. It's easy.
You take it out after a few days and allow the free drainage, or you keep this for 6 months and go on
We
changing?
keep it for 6 months. We keep it for 6 months because we leave
Go on
the valve
change-
untouched.
Go on changing this tube at regular?
Yes, you have to change, but also Professor O can tell you, it's not that you need a general anesthesia. It's quite easy to do it.
Perfect.
Maybe you just can comment on it.
So change is not a
Yes.
problem. But why not to allow the free drainage? After a few days, there will be tray form there, and you can just pull it out and allow the free drainage. possible?
No, I mean it's just a tube in. It's not a vesicostomy. It's just the tube and the puncture. And this also gives you the opportunity to clamp it. So you, one of the arguments against an open vesicostomy is that you lose bladder capacity. You won't lose it with such a tube because you can clamp it intermittently. And this just gives you 6 months time until the child is recovered and stable. And
what about the family and the parents? Do they means agree with this tube to maintain for 6 months?
Ask Professor O.
Yeah, let me just say, because so that's so I was trained in a different school when I was trained in Heidelberg, and I came here to Hamburg, and I realized that it's the way we're doing this now in Hamburg is with less complication than I've seen long time ago, and I like it very much. Of course, it is for the first approach. If you approach the parents and tell them, so you know what we're going to do is we won't touch it now for the next 6 months, and you have this catheter. You have to explain this. You have to explain why. They have to understand that all the structures are very fine, very sensitive, and you want to avoid complications in the long run. And therefore, you need time. You have time to sit down and explain it absolutely in details why you're doing this. And most of the parents are you can get them convinced, and they totally agree. And after 6 months, they were happy that they chosen this way.
Here I would
it takes time.
I would like to share my experience that when I was studying urology in subsequent few years, as we were not having a miniature instruments, we were used to do most of the time vesicostomy. And over a time, we started getting the instruments, miniature instrument. Second thing, the antenatal sonography picked up even in India, become a routine. So we started picking up these cases. Maybe we are, because of that, we have an immediate diagnosis. We do not get too much of late cases, which we are used to get. We were used to get the patients with the pyonephrosis, and we were used to do even these phyllostomy for these patients. Even Dr. Ansari must be remembering this when we were working together in Institute of Kidney Disease at Ahmedabad. But in last couple of last decade, because of availability of miniature instruments and the better conditions of the patient, we are doing primary valve fulguration if the condition is very much in favor of the patient and doing that procedure. Professor Ansari, this is very much this Professor Margrit's approach is very much different but quite appealing and thought-provoking. Would you like to ask her anything?
But I just wanted to, it is a self-retaining tube, or just it keeps going and going out so easily when the baby is discharged? How does it stay there in the position?
No, it's a classical cystostomy, so it's curved. The end is curved, and it has multiple holes.
Oh, it has
and you just put it in, and if you like to change it, it's very easy. You put a wire in, take that out, and the new wire, and then the new tube in. It's even the changement is about 2 minutes.
But one thing we are absolutely agree that any one of us want to intervene at that particular age, we must know the delicacy of the urethra. And if
Exactly.
at all, if it is possible in a very soft, very easiest way, then only we go ahead. Otherwise, we should not. That's a very perfect message that we have to take care of urethra, not giving the stricture, because that is a hell of the conditions to face by this small kid. Point well
Anil, I would
taken.
like just to make one comment, because now with the advent of such a high resolution endourology cameras available, now the complication related to the valve fulguration has become even to the tune of 0.5%.
Agree.
Yes. So putting a tube suprapubically and for a fear of 0.5%, rather it may be less than 0.5%.
Yeah, if it's a center, yeah.
Yeah,
But I mean, we don't have these huge caseload in Germany. So when these children go to a center where a valve ablation is done once or maybe every second year, once a year or every second year, it's a disaster, I can tell you. And I mean, even though we are a center for this, we don't do it as often as you do it in India. You have completely different caseloads. And I must really say, any harm to the urethra, any little harm, you will pay the price even years later. You don't see these kids during the next 2 or 3 years, but you see them later with their stricture. And as I said, if you have to fix a bulbar stricture in a 4-year-old, you have an initial success rate of 70% compared to 90% in an adult one. And I think we have to consider the whole life of someone and not just the first 6 months or just the immediate post-operative course. And you have, we already discussed it, to consider the situation in a country. If you are a high volume center and you have the equipment, yes, you can do it. But I must really say, I feel safe to use a 10 French resectoscope and have a baby that is 6 months of age. And I really can smoothly go in without pushing forward with force or anything. And even I don't touch the mucosa of the urethra, because this is really very vulnerable.
So got the very clear message, and excellent message, that those who are having the low, and we really agree that on my viewers, most of they are not getting that large volume of patient. So this is a great message for them, that only if they have a best possible case, well grown. And then second thing is that they have a miniature instrument. Third, if they are absolutely confident they are not likely to damage the urethra, they have all required instrument without compromise, then only they can. Otherwise, definitely they have to wait why either your cystostomy or vesicostomy, and only at the right proper time, respecting
And I
the
think
urethra, they have to go ahead.
this is something
Very important message. Those who are viewing this webinar, it's very important, I tell you.
Yeah, so if someone has not that experience, put a cystostomy tube in, you don't do any harm, and then you have time, you can stabilize the child, and then you get it transferred or referred to really a center. That would be my message.
Perfect.
Dr. Anil, because many of the postgraduates might be seeing this and participating in this. So, we can give an algorithm, because the level 1 evidence supports the primary valve fulguration.
Yeah.
If the facility is not available in a country like India, if the resident or the surgeon is not trained, the second choice may be the vesicostomy.
Yeah,
if
perfect.
not even trained in vesicostomy, then the third step may be that he might leave a tube, so that he may decompress and they save the baby.
Agree. And to begin with, I wanted to make that disclosure that those PGs are watching this webinar. What they have to mention means answer in their exams is that what their institutional practice and the reasoning behind that. This webinar will facilitate them for a different kind of a thought and provoking procedure. And this is how we are going to help them. But ultimately, our message to the PGs, as you concluded excellently, that they have to specifically answer according to their institutional or their teachers' method of this practice in that. And but these points are very important, and they have to keep in mind while treating this patient. We move to the choice of fulguration or resection. Very quickly, Professor Ansari, I would like to know how you exactly and which instrument means in a 7 days old child you use integrated miniature urethro-cystoscope, or you use the resectoscope with the valve 9 French resectoscope with the valve fulguration
See
hook.
yes, the size of the mattress vary from baby to baby. Sometimes in a newborn or within a 7 days or neonate, a 9 French resectoscope or 8.5 is the smallest resectoscope which is available. And there may be situation in 5% of the kids, the resectoscope may not be accommodated. Then you have integrated cystoscope, 5 French, through which you may use Bugby or the laser, whatever the facility. But we should talk which is more common. 95% of the babies, they can accommodate 8.5 French resectoscope easily.
So your choice is the resectoscope rather than the using integrated scope and the Bugby.
Yes.
You like hook electrode?
Yes, in cases of resectoscope, right angle electrode, there are some specific points why I prefer it, because it has a right angle electrode. It can easily engage the leaflets. It gives you time to identify, as well as you can easily engage it into the leaflet, and then with pure current, you may easily incise them.
A Bugby is, I think, bit difficult one. That is, I also having experience that something like a hook which can engage the wall. Yeah.
It is not active. This is rather a passive. You struggle with both Bugby as well as laser fiber.
Unless, yeah. So, do you think any added advantage with the laser fiber? I think it is probably, and now it is revealed in the.
No, it is only a big name. It does not have any advantage. I used it in 10 cases, then stop. Laser fiber has a vibration. It does not give a very precise cut.
Yes, vibration, and it will not give you a very clean cut, which you are likely to get into this. And what about your experience with the cold cut?
So many centers like Sikit, Martin Coyle once we called, so he has given a cold cut also. So the specificity, the specific reasons behind is that do not use any current, the chances of a sphincteric injury are less. But if you are careful in electrode, also right angle electrode using low pure current, the chances of damaging is very low.
Do you think with the cold cut results could be poor in compared to the using the electric current?
Absolutely. I give you one specific situation. Wall leaflets are also made. Some are made purely of mucous membrane. Some have thick mucous membrane, mucosal membrane. So if the walls are very fine, they can be easily cut with anything, with this cold knife also. And you may take a cold knife just like a sickle shape. They also get easily engaged. If the leaflets are very thick, like the way you have seen the second child where the bladder is so trabeculated, it's taking a shape of almost trabeculation circulation. Right. There are chances that you may find a terminology called as muscular valves.
Yes.
With cold knife, it really becomes hell to cut them easily.
Perfect. So, Kalpana, what you practice when you do it in a neonate, means in the 7 days or 10 days old child, how exactly, means which instrument you use and where exactly you cut?
So the instrument used is if the urethra has been having a catheter and is of about 10 French size, then we can use a resectoscope, 0-degree cystoscope, working element, and the channel with a cold knife. If it is a younger baby, we use a integrated wolf scope.
Right.
And while doing it, if I'm allowed to say, the resectoscopes when you use, if you look at the shaft, it is more or less rectangular and not smooth circular like an ordinary cystoscope. So you have to have a meatus dilated to more than the scope that you're using. So when you take absolutely. The baby, I dilate the meatus, and then I use the appropriate scope with lubrication. So there's no question of trauma. Right. The most important site for trauma is at the meatus, as we all know, just within the meatus.
So have you come across any cases of meatal or submeatal stenosis later on? Means in your
Never.
practice?
We have not come across any urethral strictures
And the trick
right
is
up
to
to
proper
adulthood, because we transfer those patients to guys and we have a liaison with them. So in my career, in the cases that we have done, we have not encountered strictures, even when we've resected valves and
submutal stenosis?
No, that's why I've said that you need to dilate the meatus to a size bigger than the scope that you're using. But meatal stenosis following cystoscopic valve resection, I haven't come across. Maybe I haven't seen many. In my center, we do 12 to 14 new valve cases per year.
Dr. Anil.
That's good volume.
Dr. Anil, just...
And I use cold knife.
Yes, Dr. Ansari, yes.
Yeah, Dr. Kalpana, I just wanted to ask one. When you use cold knife, so this sharp edge is at 12 o'clock or at 6 o'clock?
So basically, if you remember, the pathology of valve leaflets varies, but not an awful lot. So you have the verumontanum and the flimsy leaflets start from the floor, go up to the ceiling, and sometimes they spiral. So you see the valves very distal to the verumontanum. So depending on what type of valve situation you're dealing with, commonly 5 o'clock and 7 o'clock cold knife disruption of valves. I think fulguration and resection are wrong terminologies. You just disrupt those valves.
Sorry to interrupt you.
5 o'clock and 7 o'clock. And in some cases, you may need to do 12 o'clock.
Yeah. So what about the, what exactly, Dr. Ansari, what you would like us?
I want to ask, the sharper edge is toward the 6 o'clock in cold knife or at the 12 o'clock? Because most of the companies, they are manufacturing with an idea for DVIU. These sharp edges are at the 12 o'clock. So you have to bring the instrument upside down to cut the valve. So that makes mechanically very difficult.
I don't think at 5 o'clock and 7 o'clock you have to do it completely upside down. For the 12 o'clock, yes. And the way in which you do it is you put the scope into the bladder, turn it upside down in the bladder, and then bring it in the urethra at 12 o'clock position. For 5 o'clock and 7 o'clock, you have to just tilt it minimally. For the 5 o'clock, do the resection, tilt it the other way, do the 7 o'clock.
So in routine, you don't practice must a 12 o'clock cut, because in my practice, I believe that 12 o'clock cut is must. Even if I have to put one cut, then I prefer it to have a 12 o'clock cut.
As I said, the anatomy is different. And depending on the anatomy, if you've done the 5 o'clock and 7 o'clock, you immediately can see that engaging it anywhere else becomes very difficult because the continuity of the valve leaflet is gone.
Okay, perfect. Dr. Hemanth Pathak, sir, what is your practice? Means where exactly you cut? You put a multiple cut or single cut at 12 o'clock or 4, 8, 12 or 5, 7, 12, what? Hemanth Pathak, sir.
Yeah, see, we first and foremost is we don't prefer a resectoscope. Most of the times we prefer integrated scope, irrespective of the age of the child.
Right.
And Bugbee electrode or laser. Lasers, one of the two, or a hook electrode is our preference. As Dr. Kalpana and Dr. Ansari mentioned, most of the times it's 5 o'clock and 7 o'clock. But in some cases where there is circular anatomy, then a 12 o'clock third cut might be required.
Yeah.
Okay. Okay. Perfect. And any tricks to avoid, sir, injury to the bulbar urethra or membranous urethra? Means what precautions you take?
First and foremost is, as I mentioned, the size of the instrument.
Perfect.
So we undersize.
So I also not agree much with the resectoscope. If I am doing it before 8 in a 8-10 days child, my preference is the integrated cystoscope. Agree.
Second is, of course, the standard teaching. I would rather underdo it rather than fulgurate it.
Perfect.
These 2 points, that is use of infant scope. Second is, do less than what you would want to actually do it. I would rather come again if required. Right. But
Professor Ansari, any trick, any quick quick answer. Any trick to avoid the injuries?
So yes, or use a pure current and see yourself the setting, which machine you are using, whether you are using ValiLab or Martin. You should be aware, okay, what setting do I need? It should be pure current. No coagulation should be done.
Okay, perfect. And Professor Margit, how exactly means you postpone the procedure up to 6 months, and you have a liberty to use bigger now resectoscope, says 10 French, and have a good lumen urethra. But still, we would like to know from you your technique and the tricks to avoid the urethra and the.
I normally use an electric hook, and then I go into the bladder. I have a resident filling up the bladder because this is very important. You only see the valve when the bladder is full. And then I go at least back to the sphincter, have the hook out in the bladder, and then the assistant is pressing on the bladder, and then the valve comes down, and then I take the valve with the hook at the 12 o'clock position, pull it out of the area of the sphincter, and then very short fulguration, and that's it. The only thing is you can't use saline, you have to use glucose if you work with electricity. So that's how I do it. And then I take out the instrument, and by pulling on the bladder, I see how the voiding is, and if it's not a good stream, I go in again.
Okay, perfect. So I would like to take opinion from the all faculties that this is 50 minutes by this time we started, and I don't think that we will need to rush. We are going perfectly well, and if you are all having the similar opinion that I just continue with this wall only, and we'll take upper track issues sometime later, or you want me to rush little bit faster? Professor Ansari.
We are doing perfect.
Perfect. Okay. So with your permission, that I continue in the same way. I think there are so many questions are coming. Maybe I will take few online questions, and we'll leave that effort will not waste it. So I will not. I will catch hold all of you again. Maybe third time with my rest of the slides, because I have put a lot of efforts into that upper track duplex system and all those things. You have seen it. So let us go with this.
Next. Too much pain, yes, Dr. Anil.
Yeah. So this is what exactly 12 o'clock valve fulguration, or you can say the valve ablation, I do. This is so we go from there, and this is now come from after the valve ablation. Regarding the Professor Ansari, how long you continue antibiotic profile? You prefer antibiotic prophylaxis, and how long you continue? You add anticholinergics here, or you may also add alpha blockers and circumcision. When? Quick answer for these 4 points.
So antibiotic prophylaxis has to be given because the guidelines remain the same, whether it is a primary reflux or it is a secondary reflux. Although here it is a secondary reflux, but your primary job is to remove the obstruction, then take care of the bladder. And in infants especially, you have to start antibiotic prophylaxis. In which group? In high grade VUR, especially those who are having phimosis. So these are the two groups where you have to start antibiotic. Infants, high grade VUR, phimosis. While in low grade reflux, your choice. It may be optional.
Okay. And regarding anticholinergics, I have given you two pictures. 2 MCU, pre-valve fulguration. These are the MCUs, and in these patients, would you like to add anticholinergics just after the valve fulguration, or no? You don't practice that.
See, anticholinergics, if you ask me truly, they should only be given with urodynamic documentation. But I personally have used sometimes empirically also, where the child is having.
Do you predict
empirically
based on the VCUG finding?
Yes, true.
Which are the VCUG findings?
On the not only on the VCUG, the presentation. If the child, you are sure that you optimally remove the valve leaflets, you are sure, doubly sure that there is no residual wall, but the baby is still incontinent, and there is small bladder capacity for age, like in these two cases. Yes.
No, sir. My question is that I have seen in practice that immediately after the valve fulguration, patient is put on antibiotic prophylaxis, and many of the urologists, they start empirically anticholinergics. Do you practice that?
No, empirically. I take into the consideration of the clinical situation, clinical scenario, like incontinence, the mother tells the child is still continue to leak, and I see
But
cystogram.
this child is just 10-15 days.
Yes,
And
yes,
yeah.
the child, the baby is still leaking, and the cystogram, what you have shown, multiple circulations and trabeculations, and
Right.
it is taking almost the shape of a small multiple diverticula.
So these are the cases you would like to add the
Yes,
anticholinergics.
yes,
Okay.
severely
And which
trabeculated
anticholinergic
bladder.
of your choice and the dose?
Yes, usually I prefer this both. I use this
Oxybutynin.
oxybutynin as well as tolterodine both.
Okay. Okay. Perfect. Perfect. And how long you will continue? You will continue because see, most of the time we perform the follow-up VCUG at around end of the 2 to 3 months.
Yes.
And thereafter you will again decide what to do.
As an institutional practice, we subject every baby, every child to urodynamic study. We do not continue it blindly for more than 3 months.
Yeah, I'm coming to that point. Means
Yes.
to the 2-3 months later on. But till
Yes.
that, if you have put patient on anticholinergic, you will at least continue for 2 to 3
Yes,
months.
for initial 3 months, if the child is waiting for repeat
And
cystogram
you
or
add alpha
urodynamic
blockers
study, this will
empirically?
continue. Pardon?
Alpha blockers empirically?
No, not empirically. Unless I can confirm a bladder scan, the child is holding significant PVR, at least more than 20% of the bladder
suppose
capacity.
the child has come in the second month follow-up with the sonography and having a residual urine, you will add empirical, here you will add alpha blocker?
Yes, I will add alpha blocker.
Okay. And what about the circumcision? Do you practice circumcision?
Circumcision, not in all. This is again an informed decision. If the child is having breakthrough UTI in spite of my suppressive antibiotic, I teach the perineal hygiene. If I find that the compliance of the family is not good,
Okay.
in that situation, I might go for the
Professor
circumcision.
Hemanth Pathak, would you like to differ or add or anything?
Yeah, in this regarding use of anticholinergics, we don't blanketly put them on anticholinergics. If the child is voiding well, there's good stream, the ultrasound scan does not show any residual urine, then I would just follow up the child and take as the things go. Also regarding alpha blockers, if there is residual urine, as Dr. Ansari mentioned, then I would rather do a repeat VCUG and rule out residual valves.
Perfect.
Before starting alpha blockers.
Okay. Suppose if you don't have a residual valve at the second or third month VCUG, then you may add the
Actually,
alpha blocker.
Actually, it's too early to start alpha blockers.
Okay.
2 months, 3 months, 4 months, 6 months. I think, as the child grows, as the symptoms are assessed, then I will review my decision on adding of anticholinergics.
And about the circumcision?
Circumcision, I'll take case to case basis. We don't have blanket, just that all children with valve.
So Kalpana, what is your policy, institutional practice or your practice regarding all these points? Very quick.
Antibiotic prophylaxis, we give them since birth and continue it till it is required. This is an open-ended time and it depends on how the child is clinically doing. We offer circumcision at the time of primary valve fulguration.
Okay,
Many
same
parents
time.
accept it.
So valve fulguration and circumcision together.
Yeah, prophylactic circumcision.
Okay,
and
perfect.
Then if parents haven't made up their mind, we usually do a check cystoscopy 3 months later. So we do the circumcision. We can do the circumcision at 3
at
months.
that time.
With
Okay.
regard
So
to
I generally
anticholinergics,
practice the circumcision at that time because by that time they have made mind. So when I take the patient for the follow-up cystoscopy, I do circumcision at that particular time. But I do practice.
And with regard to with regard to anticholinergics and alpha blockers, we don't use any without evidence for what we are using it for, which means, as Hemanth said, and Dr. Ansari also said, video urodynamics. So in our protocol, we do video urodynamics at certain times.
We'll come to that point, but this is just, I have seen of late the practice of adding anticholinergics immediately after the valve fulguration when the patient gets discharged with the antibiotic prophylaxis, small dose of anticholinergics are prescribed looking to this kind of a VCUG.
I don't think we make decisions based on radiology. No.
You don't practice that.
We don't base any management options based on only ultrasound or VCUG. because this is a dynamic
Perfect.
function,
Agree. So,
dynamic change in function after valve resection.
perfect.
And
So
that
you
needs to
don't,
be
at
assessed.
that particular juncture, when you are discharging the patient from first treatment, you don't add any of these things. You just call the patient, put the patient on antibiotic prophylaxis, calling them up for the follow-up VCUG and cystoscopy, and at that time you may consider circumcision. Professor Margit,
Yeah, but
you means
just
you do
one
a
second.
fulguration or ablation at 6 months, but do you consider after that any of these things empirically, or you add the circumcision in your practice? Please tell us.
So what we first do is a couple of days later, after valve ablation, because we still have the cystostomy tube in, to repeat the voiding cystogram to see whether we were successful or not. And it depends a little bit on that and also on the clinical findings. And for that, I would like now to refer to Professor O, because the conservative treatment is his part of the team.
Sir, you have, Professor June, you have listened the all panelists now on this. You add your comment, or you want to differ from this comment?
First of all, you might want to believe that having this permanent catheter in the bladder may cause more UTIs, but it's actually not the case. But still, we're putting them from time to time on antibiotic prophylaxis for a while. And usually these days in Germany, we discuss the Eltern at a certain point when we terminate the antibiotics, because there's still like a little concern about the permanent use of antibiotics. And as my colleagues from England just mentioned, we also like to, on one side, to follow up on let's say ultrasound or avoiding your urography, but still it's a individual decision based on the patient's clinics and symptoms. What we decide, we in recurrent UTIs, if this appears, then at a certain point we ask for circumcision, but we don't do it like on a standard way. We just, if there's an incidence, if we are afraid of recurrent infection, then at a certain point we might discuss this. But it's not like we have this clear standard. So on a daily basis, we decide the conservative treatment on our patients.
Okay, thank you. What about the follow-up VCUG protocol? Professor Ansari, when you do follow-up VCUG?
Usually it is done at the end of 3 weeks.
3 weeks?
Yes.
Okay. And Dr. Pathak, when you call the patient for follow-up VCUG?
3 months.
3 months. So I also practice at 3 months. And before that, I generally investigate patients with the sonography. If the patient is doing perfectly well clinically, as well as sonography is perfectly going well, then I generally prefer, like Professor Pathak, VCUG at 3rd month. Any reason, sir, Professor Ansari, of doing it at 3 weeks?
Doing for 3 weeks is that residual wall. If you give another 3 months, the child may come again in urosepsis or unnecessary UTI.
But that you cannot monitor with the help of urine, creatinine, as well as with the sonography.
So sonography will not pick up the changes so early.
Okay. So regarding the clinically bladder is not palpable.
Settlement of the upper text takes for nearly 3 months, minimum 3 months.
Okay.
6 months will take change in the upper tract, and the serum creatinine also will not rise. Okay. Because to rise serum creatinine, there has to be nearly 50% fall in the GFR. So that will not be. The only thing which you can have an objective assessment is the VCUG or either check cystoscopy. That is why I advise, okay, if you want to do it at 3 months, why not to do it 3 weeks and take the decision early?
Okay, fine. And what about the cystoscopy? You do cystoscopy in all cases, or if you are satisfied in the VCUG, you may defer the cystoscopy,
yes,
or you may not do.
I do not do check cystoscopy in all, except if the wall has been fulgurated outside the institute. I definitely do myself, unless I sure that there is no residual wall. Secondly, other things, if the system if the symptom persists, whether this is obstructive or irritative LUTs, post-fulguration VUC-UG is still suggestive of residual wall in the form of posterior urethra is still significantly dilated, and there is an incomplete filling of anterior urethra, or there is an upper tract dilatation which is still there in the last 3 weeks, has not changed much. And if it has been done later, suppose it has been done by somebody else, it is coming after 3 months.
No, that is perfectly all right. But if you have done the valve fulguration at the
Yes.
suppose at the end of first week,
Yes.
then my question was just that why only after the 15 or 20 days? Maybe it is too early to judge the response of unobstructing the child. Maybe.
Yes, sir.
But agree with your comments. Kalpana, what you prefer? What is your practice? Means when you call the patient for follow-up VCUG after the primary valve fulguration?
First and foremost, we don't do a voiding cystourethrogram because of the radiation involved. And I practice, and my center practices a protocol which says we bring them back for check cystoscopy after primary valve fulguration and circumcision in 3 to 4 months' time.
Okay, so you do cystoscopy rather than the VCUG.
Yes.
Cystoscopy is the your protocol.
Yes.
Do you think any time that VCUG is more objective for that reason of a residual valve in compared to the cystoscopy?
Basically, when done for diagnosis, that's the gold standard. But subsequent follow-up, in my view and experience, it's not necessary. A, because we don't catheterize children over 6 months to 1 year awake, so we can't do a cystourethrogram. Even if I request, which I will not, my radiologist will refuse to pin down the child and put a catheter for cystogram when cystoscopy.
So what is your comment about those studies? What is your comment about those studies that they have compared the pre-fulguration cystourethrogram VCUG and post-fulguration at 3-month or 2-month VCUG, and then they established some scoring system to tell something about the prognosis as well as the subsequent follow-up protocol and some sort of understanding. That means you and your institute do not believe in this kind of scoring and studies.
I would like to say yes, we do not believe, only because anything based on a standard radiology at one given point of time does not justify the changing, evolving pathology in a valve bladder. And I would like to give an example for this. If you look at the primary cystogram, we know the radiological signs of diagnosing a valve. Once you fulgurate, those appearances change, the bladder neck comes into play, and radiology will not help over there to decide where this bladder is going to go. We have a very close follow-up where we have a MDT for all valve patients, nephrologists, urologists, nurse specialists, and combined we make a decision, but we don't do VCUGs more than a year of age of each child.
Do you believe in a strength of the study of M. Mitchell's bladder scoring system based on the VCUG, or you can say SWOT score, which is proposed based on the VCUG findings of a bladder trabeculations and bladder neck hypertrophy, having a reflux, having a diverticulum, and based on that, and with the serum creatinine or nasal serum creatinine, you can probably judge the overall recovery of that patient or the progress of the condition.
First and foremost, I find it hard to believe because I don't have experience and I don't know how it correlates. Secondly, in my experience and my practice, my center and my background, we don't need it because we follow them up so closely. We even have started doing baby bladder function assessments to check how these bladders behave. So I would respect whoever has designed this score if it helps in giving any predictive value. But in my mind, the valve pathology is so dynamic and so varied, as you have put in one of your slides, that I find it very difficult to take 2 or 3 variables and then give the long-term prognosis.
Margrit, Professor Margrit, please your comment.
Yeah,
On
I
this,
mean,
whatever we have discussed, I'm not going to again and spoiling the time here, please.
Yeah, I mean, we have the advantage that we already have a follow-up of 6 months. So we know at least whether kidney function is stabilizing or what is going on. So at least we have a better baseline and can also discuss together in the team how close the follow-up should be. As I mentioned, we do the voiding cystogram immediately a couple of days after valve ablation. So when we see that the valve isn't there anymore, we remove the cystostomy tube, and we don't do a regular cystoscopy check because we don't need it and there is no need for another anesthesia. We just follow the child on a clinical basis, and then we see what to do. And if we see that there is a trouble with bladder function, we can do an early urodynamic investigation, but also for urodynamic investigation, we would put a suprapubic catheter in, not to have any interference with the infravesical part, and then do the therapeutic treatment accordingly. And in some, really, we found alpha blockers quite helpful.
Okay, alpha blocker at the time when you do a check VCUG, which you do.
No, later on, during follow-up, when we see that there's a functional problem.
So you wait for 6 months, so you have a baseline good condition, realization of the condition or improvement, and then you do VCUG almost like Professor Ansari in 3 to 2 weeks post fulguration. Before
couple of days later on.
Couple of days later, and then
the child is still inpatient, and then we do the voiding cystogram. Then we know everything is fine, and we remove the suprapubic cystostomy.
Okay, perfect.
So that the child goes home without catheter.
So this is what I can say the beauty or what I can say. I don't have a word. The pediatric urology that. You can see that all you are giants of the pediatric urology, and still we have a different way of dealing with this patient, and most of us are having our sound arguments, and there are a lot of thought-provoking points are here, and I hope that viewers will take it in a very positive manner, and will decide what is good and what is not good in their particular setup and their practice. That is what our probably effort.
Dr. Anil, I just wanted to say, you had a spectrum of waves from days, weeks, and months for post-operative VCUG.
Yeah.
Correct?
Yeah.
So Dr. Margrit's viewpoint is that there is already a suprapubic tube. So to make a use of it, they do a dye-study and take a decision to remove it.
Yeah.
And for urethra and for stricture also, we are not interested in the bladder configuration of the bladder dynamics. So, and waiting for 3 months or 6 months for after valve fulguration. We are only interested to know the outlet, which you can come to know even after 1 week of valve fulguration. So this is one way basic. So for 3 months and 6 months, maybe good. We want to see the configuration or the shape of the bladder. But here we are interested only to know what we have done at the outlet. You can get an answer as early as 3 weeks.
Yeah, agree. So we move ahead with this third scenario, which I wanted to bring very quickly, but anyway, no problem. So this is something like we'll discuss very briefly this intrauterine intervention. I was just I checked with the Professor Hemanth Pathak. Probably in our hospital they are not doing, and probably he's not knowing even in any center in the Mumbai, any hospital in the Mumbai that is doing. What about the Professor Ansari in SGPGI? Do you have facility of intrauterine, or you have protocol of intrauterine?
No, we have some high risk pregnancy. They're doing antenatal work also, and I doing the stenting also.
So vasoamniotic shunt, you people occasionally. Who is doing in your institute?
Dr. Mandakini Pradhan, she is doing.
Miss pediatric urologist, pediatric surgeon, radiologist.
She is basically gynecologist, and she has been looking after. I think 4 years ago she had a lecture in one of our conference also here also.
No, sir. In Indian circumstances or perspective, I was just inquiring few of the friends. one of my radiologist friend, she trained at in the south part of the India, where in the Chennai and in the Pondicherry, many of these center practicing in a select cases this vesicoamniotic shunt, and they say that they are not seeing that much of additional morbidity of a procedure. They see complications related to the migration of vesicle dysfunction of shunt, but they see that benefit into the pulmonary hypoplasia and survival of the kid. But long term, they don't know because they are not pediatric surgeons. This is I have got this kind of information from the those radiologists along with the pediatric surgeons or gynecologists doing this procedure. So like to ask Margrit first you that in your institute do intervene intrauterine or in a select cases?
We as urologists, we don't do it. I know that maybe Professor O can answer. The pediatric surgeons, they have facilities and they also do some research on it.
Okay. Oh, yes, Professor O, June. Yeah.
Yes, but it's still on research-wise in our university. I think that there are only a few places in Germany where this is performed. I think two centers, and some centers are thinking about it, but still based on the lack of really solid evidence and the possibility of major side effects. Everyone is a little bit hesitating and waiting for studies to be published to show the long-term benefit of these procedures.
Yes. Okay. And Kalpana, how exactly you counsel this patient? Means your expertise is there that you have a now pregnant lady in a late second trimester or third trimester. See, in India, generally the trend is that if very rarely we picked up this before 20 or 24 weeks, where we are still legally able to advise them to terminate if they want, right? And they many of the times, because see, if you look at this study which I have mentioned here, the most common treatment for valves identified in utero is fetal termination. It's a congenital urinary bladder outlet obstruction. This was the article published in 2010, and I'm quoted in many of these further books and the in the other articles. So what you miss, we have options here. If we picked up before 24 weeks, sometimes patient these parents go ahead with the medical termination of the pregnancy. If they are in a well shape, means there is no oligohydramnios, kidneys are good on sonography, they continue with the pregnancy, they deliver child, and we treat subsequently. In a very severe case where the dysplastic kidney is not there, then we inquired to a center if they are wanted to go ahead with this intrauterine intervention. So, and at times, some gynecologists or pediatricians decide to deliver this child, taking the risk at 30th week with the keeping the patient in NICU, where I've seen worst, this is the probably worst thing I've seen, that they get exhausted financially as well as medically, staying into the neonatal ICU for long, and thereafter also they this child survives with a lot many other problems and the complications. So we would like to know from you how you counsel and how you treat.
My word, what a question and what a topic. I can spend more than a day talking about it.
No, but we give you at least comfortably 3-4 minutes, please.
Okay, basically, it's not an easy counseling. I do the counseling along with pediatric nephrologists, neonatologists, and the nurse specialists who are involved in their care, because it is very complex. It also has to be tapered to the level of understanding of the parents. It is absolutely no point giving them, throw the book at them. It doesn't work.
Perfect.
Especially when they're stressed. So you have to break it up and give it to them in palatable quotients and amounts. You may need to bring them back to answer their queries. You may need to send them home with written information and a telephone contact so that they can liaise with you. And in an ideal setup where the parents have understood everything, they understand, it is the parental decision by which we go. So you may have a 24, 26 week, you may have a earlier pregnancy where the parents have seen the poor prognostic indicators, which means the writing is on the wall, yet they decide to continue pregnancy to term. And we cannot intervene there. We only support.
Okay.
In other situations, if they've come to us early enough, or if the diagnosis is done on the 20-week Anomaly Scan. Now again, the scanning is different in different countries. So in my center, you get a pregnancy scan, and then straight next is the 20-week Anomaly Scan. If it is picked up at that stage, then we encourage parents, depending upon the behavior of the kidneys and bladder on the scan. If it is stable, we don't do much. If it is changing, we don't wait too long before advising them prenatal drainage. And then you take them through all the ethics and everything of prenatal intervention. It is not taken lightly, simply because, as we know, it is associated with morbidity, mortality, loss of pregnancy. However, we don't hold back either. So I counsel in both St. Thomas's and King's College, and some of you may know, in King's College is Kypros Nicolaides, the god of fetal medicine. And he does shunts so efficiently, so efficiently. In his career, he has done, in his entire career, he has done 41 psychoamniotic shunts. So from that, you will know how rare it is, because valves are not a huge amount everywhere. And that's a referral center for the whole country.
Okay. So
having said
that work is published, or no, it is not much in a public?
No, Kypros doesn't allow retrospective review. I went through the cases and I found out 41 cases shunts were done, and majority 27 were for valves, and the other one was for cloaca and other condition.
Okay.
So the answer to your question is, it's not an easy thing.
Absolutely.
It's a skill required.
Yeah.
It is a skill required. The skill rests with either obstetricians or fetal medicine specialists, if those are available. And urologist just holds their hand, for want of a better word.
Right. Okay.
So I won't say that it's very easy to do. It's very technically challenging. As you can imagine, it's a moving object.
That there is no much additional morbidity of a procedure in a well-trained center.
Even in King's, which is the mecca of prenatal intervention, not only for valves, but for everything else, even there, the mechanical problems of shunt displacement, having to replace it, are known, are there, even in their hands and their experience.
Okay, perfect. Okay.
So I don't think it needs to be taken lightly.
Any answer on this, just quick answer, that why this Pluto trial, PLTO, means terminated?
Basically, it was flawed right from the beginning. The principle on which they recruited cases was based on the clinician's decision. So there itself, it was flawed. Second, the numbers are not so vast, and they aim to enroll 150 and were able to enroll only 23 or a figure like that.
Okay.
We raised objections, and then we brought the follow-up postnatally to 5 years of age to look at creatinine. But in the end, the analysis showed such a poor confidence interval and such a vast range that the results were not reliable. And we had predicted that at the very beginning. So it's not easy to do these trials.
Few last word from you on this particular issue.
Yeah, can you click forward, because this is just a summary of a mini review I found, which is quite recently, out of the year of 2019. And it was stated that prenatal intervention improves survival in the worst cases by improving pulmonary function. It may be advantages for renal function, particularly in patients with the adverse urine parameters, but high complication rate. Vesico-amniotic shunt 40%, and fetal cystoscopy fistula rate of 8.8%. a 5.9% recurrence of LUTO, and it may lead to preterm delivery and death after birth. So I really agree, the literature that it's safe and that it helps is really not out.
Okay. And what I learned from my friends in India, those who are involved in this in the south part of the India, that they see more complications. They were seeing worst possible complications with the fetal cystoscopy, and that's why off late their choice is the vesicoamniotic shunt in compared to the fetal cystoscopy and the wall ablation.
Can I say something, Anil?
Yes, yes, please. Please.
Basically, the world over, in South America, US and France, there was a collaborative study, 2018, I think, or early 2019, I don't remember. In the world, 41 cystoscopies were done. And you have, if anyone is interested, they should read that article to see what the difficulties were, as Margrit presented. In their experience, the fistula rate, urethral trauma was about 10%. And then they improved on their techniques. So if in the world 41 cystoscopic approach to prenatal valve bladder is done, where does a single individual in a single center stand in terms of experience? That's it. Thank you.
Okay. So that brings me on a next issue is that this is the particular case where you can see this voiding cystoscopy, which was done on second day of the birth or second or third day. Here there is a massive upper tract dilatation, acidosis was there, which was taken care by the pediatrician in my case with a high serum creatinine. Patient's weight was 2.5 kg. Patient was in acidosis, creatinine 3 gram at second day, which came down to 2.8 milligram on third day. And then subsequently, the nadir creatinine was around 2 milligram at the seventh day of the drainage. So my question here is that here I want to bring the discussion that in this kind of a situation also would like to continue with the long-term catheter drain and see that when we reach the best possible creatinine and go ahead with the primary valve fulguration, or looking to this scenario, we can decide very quickly on the possible diversion. Professor Hemanth Pathak, with you, what you would like to consider in this patient? After that, I will go to the Professor O for some words about the treatment on these particular conditions to stabilize the patient. But here you consider the patient is stabilized, and this is the scenario. Massive.
Yeah. Now see, I would go the same way as we discussed, that once the child is stabilized, maybe the catheter is going to remain for a longer time, maybe 8 days, 10 days. And when
creatinine still remains around 1.5.
Yeah, whatever the level of creatinine, I'm not going to
clinically stable, but not improving much.
Yeah, meaning creatinine is not going to be the final deciding factor.
Right.
Once the child is stable, is biochemically stable, his metabolic thing has been settled, and once the pediatrician gives me go ahead with the procedure, I would go with the valve fulguration and then take things as they come, step by step.
Do you think
Only
considering the clinical scenario and this VCUG, at any point of time, you think that diversion will reduce chances of multiple anesthesia, multiple procedures, and related morbidity, and occasionally even mortality?
That's what I'm trying to come to. That 15 years back, we used to see these images and just do upper tract diversions, a ureterostomy. But over last 15 years, the management has completely changed. We take step by step. Not every child is subjected to diversion. He's subjected for fulguration. He's followed up with antibiotics. He's followed up biochemically. And if he's doing well, then we continue the same line of treatment.
Okay,
if he doesn't do well, if he's not doing well, then of course the treatment
doesn't do well means creatinine and upper tract dilatation are the criteria, or what?
The creatinine is rising, mainly, these children clinically not doing well, meaning the infection continues to remain.
Yeah.
The child clinically is not looking well.
So do you think, sir, this VCUG and initial presentation gives some little bit of guide that this child likely to be remain in a repeated sepsis and some clinical problem, and for that reason, likelihood of going for a second procedure in the form of diversion is there, and in that circumstances, do you consider diversion a kind of a proactively in considering this situation?
That's what I'm trying to tell you. We are not proactive on diversion.
Okay, perfect, sir. I got your point. Professor Ansari, you are differing or no?
Yes. Serum creatinine. What is the age of this baby?
It's immediately after the birth. This was sent to my center.
My cutoff for any intervention is, if it is within 1 year, is 1.5. After taking all precautions and giving conservative trial right from 1 week to 3 weeks. So, and at the age of 2 years, when the adult GFR is at 10, then I take
Sir, this patient is of around 5 to 7 days only.
Just I'm telling you. So for me, it's 7. Is the last creatinine is 2.8 at 3 days. Okay. So
thereafter the 7 day the creatinine dropped to 2. Patient is comparatively stable. But
so this is also not fitting into my criteria of creatinine, and I am more worried. If you see the tortuosity of the ureter, and on the specifically on the left side, if you see the kind of footprint sign, which is also giving impression of secondary UPJ obstruction. So if you keep feeding tube here, not only for 3 weeks, for 3 months also, this is not going to improve. Here, I would like to go a ureterostomy on the left side, and the reason is that this will put the entire system on rest, and this will give some recycling of the bladder also, and this is going to drain on the right side also. So
Margrit, your thought? You will consider diversion in this patient, and which diversion?
Ureterostomy, left-sided ureterostomy.
I agree, sir. Now I'm asking Margrit.
So we have, I mean, when I trained, we did a lot of high urinary diversions, but I think there are a lot of data out that in a long run, it will not really have a benefit on kidney function. I will show one of these studies. So it's really a very individual decision, what we take together with our pediatric nephrologists. So as I said, we would follow first with a cystostomy and then see. And if we have to do a diversion, we either would do a nephrostomy tube if we think it's for a short period. If it's for a long period, I was trained to do a high diversion. That means a pyelocutaneostomy, which leaves the complete ureter intact and untouched, and which is quite easy to close later on. But I would like to refer to Professor O, because he would first take
Professor O,
and try from a medical point of aspect to improve.
Professor O, Margrit has put the cystostom in this patient. When you feel that you will suggest Margrit to do diversion in this particular case? How long you will, how exactly you will treat and how long?
Okay, so the idea would be actually that we take a look at the patient and get the feeling whether there is kidney function to preserve, whether it's already too late and we already at the end of it, or there is something we need immediately to rescue. I think this is for us a very first important step, and to decide which way we're going, which speed we are taking on. So if you believe that we have a kidney function to preserve, then I think that depending on the rise, on the change of the creatinine, we follow very closely, decide at which time point we need definitely some surgical intervention. And I think that's the way we approach it, this. So
she did a cystostomy. You taken care of acidosis, electrolytes, and all those things.
Yes.
The creatinine dropped at the 15th day at around 2, and the upper tract dilatation on sonography is reduced little bit, but still persists in a significant way. Now, in that circumstances, will you still continue with the cystostomy, or at that particular time, at which time you will insist for the diversion, which she is talking, pylostomy?
Okay. So I think that the decision will be once the patient is stable, once we realize that it's going to be like a permanent situation and there's no relief on this acute intervention, then usually we ask for the diversion at a certain point. But it's again, it's not. I'm really not into this very strict weeks of just. It's again always an individual decision in our hands.
Perfect.
And it's because it's a dynamic process, and I think that's how I try to teach my fellows that it's not just follow standard of procedures. It's just by taking one by one puzzle piece and see how dynamic, how is the process.
So very quickly, I will share my experience practicing in me, because many of the viewers are practicing like me, right? Here, when we get this child, this kind of a child, the parents are very much anxious. And when we think about this particular case, we have to think the minimum procedure possible with the least morbidity in kind of a thing. Means they want a procedure where we think. So in this particular scenario, at least I think in my practice, to go ahead with the diversion, which Professor Ansari suggested, the same kind of diversion, almost very quickly, probably in the first week when the patient is clinically stable, to avoid the possibility of multiple procedures and a best possible recovery. Though I know that it won't make in a long term, might not make much difference in the renal recovery, but still the patient gets stabilized with the help of diversion. Kalpana,
Yes.
what you exactly do in this patient at the end of 7 days with the creatinine of 2 and clinically patients split stabilized with this picture?
As you've given your background and the practice of your background, I entirely voice the same decision that a loop, not an end ureterostomy, allows decompression not only of the ipsilateral side, but even of the contralateral side. And rejoining the ureter at a future date with a ring ureterostomy, which is also called as a refluxing ureterostomy, is much easier. But at this stage, I would like to make a comment that in the setup that I practice, this appearance is very significant of pinching of the ureters as they enter the bladder. Once you resect the valves, what happens is the bladder collapses and it's very often no longer over-distended, and the thick muscular bladder pinches off the ureteric orifices and gives rise to this kind of dilatation. Now, that pathology in some patients persists on to give rise to urinary ascites, further dilatation, etc. But in some, it recovers with secure drainage. So I would like to point out to your trainees to keep that in mind and not just jump to a surgical intervention. But having said that, your background for practice and your parents and all, and the economics of medical care, etc., in that scenario, I think a loop ureterostomy is very much warranted.
Okay, Margrit, you would like to comment? You wanted to do some comment.
Yeah, can you just forward the slides, the next one?
So this is what I did.
A couple of discussion slides.
Just wanted to mention that this is the what exactly
okay.
I do this kind of a patient. Yeah, come, yeah, please.
Yeah, so this is also from the literature. There may be a possible benefit. However, the question is it long lasting? And it's the baseline renal insufficiency will at least progress independently. And disadvantages if you do at least a vesicostomy, it impairs bladder dynamics, and it's undiversion again, whatever type of high urinary diversion you do requires additional anesthesia. Next. And the next slide, please. And this was also a recent publication, and you see the different curves. The blue one is ablation only. The green one is ablation and vesicostomy, and the gray one is ablation and ureterostomy or pyelostomy. And you see that at the beginning, there is a significant difference, but with longer follow-up, at least all the three curves go together. And you see the median follow-up of this group was 12.4 years. And I think that's a very important information.
I would like to sort interruption to you here. That is what exactly the point I wanted to bring, that many of my viewers are practicing in the scenario which I am practicing. And in that case, we want to reduce the initial treatment morbidity, hospital stay, and the cost of the treatment. And that's exactly reason that we prefer to have a quick decision on the diversion. Yeah, please go ahead.
So, and when you could continue, please, the next slide. So that is the summary of this study. They said it may provide a temporary preservation of renal function, and it may delay time to dialysis. However, in the long run, there is no benefit with respect to rates of ESRD. And I mean, there are other predictors of ESRD that are more important. So, and I think this is important to know. It gains you some time, and you have to discuss that with the parents, but in the long run, you will not protect kidney function.
Perfect, perfect. But initially, it is having some advantage. Yeah, Professor Ansari, as you agreed with this diversion, you practice valve fulguration along with the diversion, or you only do diversion and let the patient stabilize, and thereafter you take a call for the valve fulguration and subsequently.
I just a comment regarding this this sick kids study. Say what we are talking. These are the cases. This is a retrospective review, and these are established case of ESRD 3. I think they have studied the ESRD 3.
Yeah,
and ESRD 3. By diversion, we will be able to get the nadir level. Maybe that they might not be belonging to ESRD 3. He might come back to ESRD 2, or you never know. Surprise that they might also come under the group of ESRD 1. So they might be benefited. So we have, by the definition of CKD, you remove all the reversible factor, which we have not done in this case. So by diversion, we have removed the reversible factor. At least we have given a chance of 6 weeks to 3 months, removing all obstruction. Then this child should be kept into the category of to which group of ESRD is being CKD is being kept. You never know that he may fall back into ESRD CKD 1. So he may be benefited by subsequent valve fulguration. While in this,
And I'm adding a few of the things as I'm practicing in the periphery. When I came over here in the first 5 years of my practice, I saw many of these patients diverted before 18 years. And to my surprise, they have perfect kidney, means much improved kidney, having a good growth of the bodily growth. And when we look at the bladder capacity is also comparatively not much affected. So I here tend to say that we probably, as the pediatric urologist, maybe sometime we are missing that long-term follow-up because either the patient is moving or the person who is doing that procedure is moving. But here in my practice, at least I get opportunity to follow this patient at least 10, 20 years. And in that circumstances, I do see the advantage in this kind of a patients with the diversion, that they get the best possible least morbidity, no repeated hospitalization, least medications, and the best possible chances of recovery.
Yes, but may I say something? Yes, that's because that's my daily work actually, to follow up these patients after 15, 10 years of urological procedures. And I think that because we're almost at the end of our webinar, I think what we need to have is like a kind of closer collaboration to look what actually really happened to all these patients. Once they reach, they have this
to know your experience, your 10, 15 years of experience, which will believe much more in compared to the any published data or guidelines. Sir, please continue.
I mean, but if, of course, but I think that if we all together, like urologists, pediatric nephrologists, have this long-term follow-up registries and look what's really happened to these children at the end, or at young adults, because I do see, some of these patients, with this impaired kidney function after 15, 18 years, they're probably not CKD4. But again, for me, I also transfer them to adult nephrologists. But then it's already so many years apart from the initial operation, and we lose track on all these patients. Probably the benefit is stronger than we believe. Probably it's less. We have to, we have to do more of these long-term follow-up studies to see. Of course, prospectively would be nice, but retrospectively, because I have to address so many questions, and young adults, teenagers asking why my kidney function is so bad. I had this operation long time ago, and all these parents are asking these questions. So I think that's something we should do, because the techniques are getting better and better, but still, of course, the amount of experience are getting less. So before we decide to go new ways, we have to make sure that we're following the right tracks. That's what because I have to deal with these patients every day in my outpatient clinic.
Perfect. Yeah,
Just
thank you.
one
Excellent.
small
Margrit.
comment.
Yeah, please.
What I have seen, because I'm also an adult urologist, so we can, and that's really unique, follow these patients till the end of their life. And what I have really seen is that during puberty, some of them deteriorate, and I don't know really why. And they are doing fine till the age of 14, 15, 16, sometimes 18, and suddenly, they show up with upper tract dilatation, the kidney function goes down. And really, before we discuss things, what is good, what is bad, our personal experience, we clearly need data, and we only can rely on data. And there are no prospective data available, a few retrospective ones, and really we need these data before we can give a definitive statement. Is it useful, yes or not?
Professor O,
can I just comment as well?
Yeah, please. Professor O, do you think that this sudden deterioration after a certain age, that is could be because of increasing blood make resistance, means voiding resistance, and because of that they are voiding with the pressure, which is deviating to the upper tract, directing to the upper tract, and there are possibility that increase of the hyperfiltration injuries, and they pour more amount of urine, specifically at the night time. They start coming with the nighttime incontinence again. That time they convert into the daytime incontinence because they try to hold it with some maneuvers, and that is how that cycle sets in. So at that particular means periodically 5 years onward with the toilet training, do you think that we really vigorously focus on the how the urine is getting stored into the bladder, and how with the what pressures they are voiding, with the help of non-invasive sort of urodynamic study, and maybe if required a clear-cut urodynamic, and addressing their intake and output and all this emptying and double emptying, time emptying, and maybe CIC, maybe nighttime catheter drainage, and all these things. Do you think that we can salvage many of these patients going ahead with the ESRD?
Oh, that's a good question. I think that on one side, if we can solve the problem of puberty, we get the Nobel Prize. But it's just a question of adherence and compliance, and it's some point to understand. So there might be two different, as I see it, two different ways. One, you have the patient with his adherence following the let's say the recommendation of urologists, of nephrologists, to have a permanent or regular frequent voiding, and just forgetting it, and going out night clubbing and whatsoever instead of going to the toilet. This is one problem. But then again, the other thing is, what I'm really also interested in currently is actually the function of the hormones which are produced in the puberty. Usually in the old time, we believe that the sexual hormones are only based for the function of the sexual organs, but I think that there's much more into it. And with the changes with the influx of hormones and estrogens, I think there's a process ongoing that may also influence the impact or the function of this already injured organs. So I think that, of course, if we find a way to approach our teenagers, if we find a way to identify the risk factors, risk patients with a particular characteristics, and we try to focus on these patients and train them better, get them to understand better understanding their problems, we might have some benefit for the long term. But I think there's more behind this.
To me,
Anil, can I make a comment?
to me, PUVAL is a never-ending story, and we have to take in that way that we have to carry this patient. And being a like Margrit, pediatric urologist as well as adult urologist, and sitting in the one place, I at least get opportunity in a couple of patients to follow these patients for a long period of time, and where I get chance of looking completely. Means once intravesical obstruction is taken care, I just focus mainly on the bladder and the kidney pouring the urine, which is because of lack of concentrating ability. And if we really address together all these issues, probably we can definitely salvage few of these patients. Yes, quick comment from the Kalpana and other panelists. Yeah, please.
We have a database, a prospective database. We have 200 valve patients on it. We have analyzed those. We have done studies at 5 years, 10 years of age. One pediatric urology colleague has followed up the babies from birth till adulthood, and we have presented in meetings. And the basis is not at puberty. It depends on kidney function. So our valve clinics are the well valves and the complex valves. So if you start off with poor kidney function at puberty, when the demand on the body is massive, they may not do well. Also, the drinking and other factors change through the milestones of life. That adds on to the thing. Compliance, teenagers don't come for follow-up, nephrology, routine follow-ups. So it's very interesting. We have presented all this data and it is being written up. So it is all there, prospective. We follow them up till 16. We have an adult urologist who takes them between 16 and 18. And then in guys, the adult urologists look after them till end of life.
So what is the outcome? Do you think that focusing on all these things, their proper follow-up, their drinking habits, their avoiding pattern, and addressing all these things, do you think that if we constantly work on that, they can have a better chances of long-term wellness? Yeah.
Definitely. We involve the nurse specialist and psychologist as soon as they enter puberty.
So what I retrospectively think about that, many of the studies, they claim that it doesn't make much of difference, right, in the long term. I think they have not really properly included all these factors and the parameters to look in for the long term. And then when it reached to the ESRD or the dialysis or transplant, they calculate how many patients contributed by the PUVAL, but why it has been contributed, and at what level the patients started deteriorating, and what the factors were not looked after in the long term. I think that area needs to be addressed very
True. Basically, it is the level of kidney function at the beginning which predicts the outcome. The other milestones of drinking, puberty, adolescent adds on to the insult if the function has been poor. If the function at the start has been good, then it doesn't make so much of a difference. So the outcome, the far end outcome, depends from where you started your kidney function in boys.
And then how you long-term taken care of those marginal patients?
Oh, we have valve clinic, 4 valve clinics a month.
The results could be from the where we start, but in a marginal patients, the patient how he respond in long term, and the clinicians long term they manage. I think there can be, and a good number of patients can be prevented to go ahead with this long-term dialysis or the transplantation.
Yeah, my pediatric nephrologist follow them up so frequently. So their growth, their electrolytes, everything, they look at it. We bring them into the MDT valve clinics, and there are 4 valve clinics in a month. So they are followed up that closely. And whatever intervention is required, non-urological, the pediatric nephrologists do it. So it's the timely interventions in
Perfect.
terms of
So that is
management.
very
which is
important and a great message. And now we have a quick comments from each panelist on these particular discussions which has taken place in last 10 minutes, as well as I will take another 10 minutes to finish this last case. So give me liberty of 10 minutes and quick comments if you want to do on a long term, kind of a need of a long term look at these patients, all from Professor. Oh, yeah. Start with you. A quick comment. Can we really miss nadir creatinine at the 1 year? Maybe a very good prognostic factor, but on those marginal patients, can a long-term care of the storing and voiding and long-term care of the filtration from the kidney, if we take care perfectly, then many of these patients can be have a better life quality of life. Yeah.
Yes, definitely. But we have to take a very close look at these patients for a long time to follow up and see an identified risk situation where we can help these patients on and try not to lose them in the transition to the adult nephrologist or the adult urologist. And but yes, I think I agree with you.
So, Professor Ansari, what is the policy in your hospital?
Hello.
Yeah, Professor Ansari, what is the policy in your hospital? In those marginal patients
Yes.
who probably after your diversion did well, but on long term they don't get deteriorated. How exactly you follow these patients?
Say, if you long-term follow-up, we published it almost 6 years ago, our long-term data. We have almost 700 case data, and that showed it nearly approaching to 15, 16 years, nearly 40 to 50%, they slip into the CKD. And almost 11% at 10 years, they slip into ESRD, 11%. So what happens to the remaining? The longest follow-up we are having up to 25 years. And some of these are maintaining serum creatinine even at the age of 30 years. One of them is doing MS surgery from UP itself, and is maintaining good serum creatinine. And another boy was selected this last year in engineering also, and his age was around 22 years. So nearly 15% of the adolescents, they continue to have their serum creatinine within the range of 1.5 to 1, and but their upper tracts both are still remain dilated, yeah, either one-sided or both-sided, and the bladder is most of the time is decompensated, underactive, and you treat it accordingly.
Okay. So quickly, I'm introducing this case, having a 4 slides. This is a son of a radiologist who himself picked up in a second trimester sonography of his wife this condition in the fetus, and then he himself performed on a first week this VCUG, and this VCUG was suggestive of posterior valve with bilateral reflux. The child did well with the catheter drainage, which was nadir creatinine was achieved in a week. 0.6 milligram percentage, and a procedure was done at the end of 1 week, which went uneventful. He was kept on antibiotic prophylaxis. Empirically, we add anticholinergics. We didn't opt for the alpha blocker. And then this is the VCUG, which was done at the end of, there was a one VCUG at the end of 3 months. Was compared, there was no residual valve. We didn't perform the check cystoscopy in this patient. And then this is the at the end of say 2 years, this VCUG and the DMSS scan, reflux is still persist. And in this sort of a cases, Margrit, what you advise?
So if the child has no febrile urinary tract infection, I just would follow.
No, child was asymptomatic. He was kept on antibiotic prophylaxis till 1.5 years of age. Right? After we stopped the antibiotic prophylaxis, child was doing well. So we performed this investigation at the end of 2 years with this VCUG and the DMSS scan to know the baseline means upper tract conditions. Yeah, please.
Yeah, as I mentioned, I just would follow. I wouldn't touch, because you see that there is an improvement. Just wait a little bit longer.
Okay, so in this case, at the age of 2 years, with this reflux and with this renal scan, perfectly all right. You would like to do urodynamic, add some medications, or no, you will not touch right now much of the things, and just keep good close follow-up.
As long as the child is without symptoms, can void without residual urine, has no urinary tract infection, I just would follow.
Perfect.
And you even can discuss after 2 years to finish the antibiotic prophylaxis and just follow. Yeah.
Okay, perfect. So this is the, though it is not a great VCUG, but we did at 3 year, child was not much cooperating, but you can see that there is no reflux. So what we looked after is that regular check, clinical check, antibiotic prophylaxis till 18 months, oxybutynin we add, and then toilet training, we focused on that, and fluid intake output chart with the regular sonography with post-void residual. And at the 3 or 4 years of age, we even did a uroflowmetry, sort of a non-invasive kind of urodynamic together. And we were even monitoring the fluid intake output. And 3 to 6 month urine analysis, renal biochemistry, USG, blood. So this is what exactly, and recently I requested him before only a couple of days for this webinar to give me the sonographic findings. This is child is now reached to 14 years, the radiologist son who is practicing in my neighborhood. And this is the exactly condition of left kidney. This is the right kidney, no increase in echogenicity, CM differentiation is well managed, well maintained. Left is little shrunken kidney. This is the condition of bladder, and this is the post-void residual urine. Kalpana, quick comment on from you for how you exactly treat the bilateral reflux associated with the valve, and which is there still when you follow a patient at 1 or 1.5 years of age. Patient is asymptomatic.
Yeah, as I said previously, we don't treat radiology.
Right.
So we will be guided by the clinical behavior of the child. And
Right.
in this situation, he's asymptomatic. So we just follow him according to our protocol.
So what that means, you do cystoscopy or sonography and biochemistry? What exactly you do?
At each follow-up and at each milestone, we do different investigations.
So for reflux,
those investigations,
for having this reflux of such a massive reflux, do you consider VCUG at any time of your follow-up in an asymptomatic child?
No.
Whether the reflux is
because
reduced?
We don't treat radiology in valve babies or valve patients. So there's no need to do MCUG. We are guided by the nephrology follow-up and urodynamic findings and the general well-being of the child.
Okay. When
so
you
the
would have
VCUG
considered,
has no role.
When you would have considered urodynamic in this patient?
We do urodynamics. We've started doing urodynamics very frequently in the first year of life. Previously, we used to do it only once.
Which are the criteria which pushes you urodynamic, or urodynamic is a routine protocol? Yeah.
And for a pubertal child, we just do it around 12 to 13 years. And we do urodynamics then. And if the parameters are fine and the patient is asymptomatic and continent, we don't do anything. We involve the pediatric psychologist.
Also, I think urodynamic is also a kind of invasive investigation, which requires catheterization and also many of these invasive things where we need a child cooperation. In a patient who is clinically doing perfectly all right, why not to have a sonography with post-void residual intake output chart, means water intake and the output chart, and then at times uroflowmetry, and just at the most required then voiding cystoscopy. Why not? Why in compared to, I think, urodynamic, these are the things little less invasive.
Yeah, the protocol includes all these things that you've mentioned. And in a cooperative child, like he's 14 years, he can make his own decision. Some children say they don't want the catheter, so we don't force them, especially if they're asymptomatic.
Okay.
But if they're amenable, then we do it, because when we transfer their care, if we do it around pubertal age, then you don't need to do it at 16 years when we transfer them to the adolescent urologist. And if it's not done around 14 years for various reasons, we, the nurse specialists and the child psychologists, prepare the child for urodynamics, because that's important, valuable information for the child to take as they leave the pediatric urology and nephrology follow-up.
Professor Pathak, how you deal with this bilateral reflux associated with the valve? Suppose if you are treating this child and you've seen the 2-year reflux is fairly there, but child is asymptomatic with the upper tract functions is well maintained, then what is your policy for the reflux?
Policy for reflux is not to treat reflux.
Absolutely perfect. So that
and
is
monitor
why,
the child.
why I'm repeatedly asking that many of the times in our discussion, we get this question that in a persistent reflux, why not to go ahead with the reimplantation? So just give a proper message, sir, to those questions. Yeah, please.
So as you have mentioned, child is doing extremely well. Urine parameters, biochemical parameters, clinically is doing well. No breakthrough infections. Even in breakthrough infections, unless one is really pressed because of repeated infections, then only there would be a possibility of treating reflux. Otherwise, reflux.
There also, I think, there also you will focus first on the bladder dynamics.
Yes, yes. I am taking that unless in the corner, nothing is working in your favor. Child is coming repeatedly with breakthrough infections. That would be one of the very, very rare scenarios where reflux might have to be addressed.
But then also first we have to look at the bladder dynamics. We have to look at the how much kidney is pouring, how the child is voiding, and all these things once we address. Professor Ansari, what is your views on this? This is the last few minutes, and we wind up this discussion. Last comment on this particular case and how to deal with the reflux.
Absolutely, because we need to understand that this is secondary reflux, and this reflux is because of outlet obstruction which has been taken care, and now it is because of the bladder dysfunction. Could be. So, yeah. As Dr. Pathak said, bladder dysfunction should have been taken care or addressed first before we talk of the reflux. So, and in cases of posterior wall, all possible chances, like in primary VUR, should be given for spontaneous resolution of approach after stabilization of the bladder. And there should be a very, very, very high threshold for intervention in cases of posterior wall, not only in PUV, in neurogenic bladder also. So before you intervene, whether in terms of a sting operation or surgical reimplantation. So unless the child earned it, in terms of breakthrough infections, recurrent UTI or pyelonephritis, then touch these children.
And along with that, you give a message that you adequately address the bladder function, yes. Voiding function, means storage function, voiding function, and how much upper tract is pouring the urine with the fluid intake output chart and all those things are well addressed. And absolutely see, the thing is that the last word comes, I have not yet done any of this reimplantation. And the reflux, though it is considered as a bad prognostic factor, bilateral reflux, but in my clinical practice, probably I haven't seen much the problem with the patients who reflux. If you look after all the infravesical obstruction properly, blood dynamics properly, the output issue properly, intake issue properly, and then give you exact idea about how frequently to void, how much to store, I think rest is so. Yeah, Professor O. What is your comment and how exactly the patient, see what happened, these patients when reaches to the toilet training, they try to avoid the frequent voiding, and because of that they start certain holding maneuvers or try to avoid the urination, and that is how they sets in that cycle of storing at high pressure, diverting that pressures to the kidney and all those issues. So what exactly, how you counsel this patient of a persistent reflux?
What we offer these patient is urotherapist meetings to try to get them trained, which is like on a frequent base. They meet the therapists and try to get used to this, to get into this schedule of frequent and permanent voiding processes, and try to teach them before we do further interventions. And it works very nicely, actually. It's an approach where psychologists and trainers are working with these teenagers or these children.
Okay, so it is now, we are almost 8:15 and we are exceeding 15 minutes. And I'm very sorry that I send you many things to discuss, but we could take almost 1/3 of this scenarios. But with your permission, we continue discussing in this speed or space. And I really thank you all for giving a time patiently this much of time and enlightening us on various of these issues with your own experience and institutional practice rather than too much talking from the literature and the guidelines. And though we are differing in several of issues or having a different method of the treating this patient, but definitely it gives a lot of thoughts to think our in a long term and thought-provoking procedure. And I really enjoyed this, and I hope all of you have enjoyed. And with that, I thank you, Professor Margrit, Kalpana, Professor June, Dr. Ansari, and Dr. Hemanth Pathak. And once again, thank you to this awesome platform, Urology Learning Through Others' Experience. Nitesh Jain and his team worked very hard in last 2 months to bring all these things to be possible, broadcasting day in, day out for all of us. Thank you very much. And with that, I will take again permission from you to come on this platform, say after 3 or 4 weeks, to complete some of the very interesting discussion on the left out PUV discussion on long term, as well as the upper track certain dilemmas of duplex system. Thank you very much to you. And have a last comment from all of you. Yeah, Margit.
Bye-bye. Thank you for setting up all this and the nice cases.
I think you don't have any problem with this speed of this pace of the discussion. Okay.
Anil,
I'm sorry that many of your brilliant slides are with me, and we'll definitely bring you to complete the discussion. Sorry for that. Right.
Anil,
Kalpana, yeah, please.
is there any way, not a very detailed or this thing formal, but is there any way of getting a feedback as to what they understood and what they would like further
We do take feedback. See, they go on feeding the questions. Right now, around 50 questions are there, and we have probably not incorporated these questions. We'll definitely answer those questions from our side, and we go on asking. See, this PUV discussion was long pending, and PGs only wanted me to come with this PG, and not to speed up and not to have a bigger pace. The reason is that only that we want to satisfy the PGs mainly.
Yeah.
So we'll definitely give you the feedbacks which we have given to Margit in the last webinar, that how many people appreciated, how much comments, PGs comment, and what the viewers, how many viewers watched it. Yes, Professor June.
No, I want the negative comments more than the positive.
Yeah, perfect. See, the thing is that maybe people will criticize that we wanted to listen much more varieties of the scenarios, but maybe I think all of us will agree to even begin with when we were discussing on males that whatever amount of cases we can take in a detail, we'll continue with that. Yeah, Professor June, your last comment on this webinar.
First of all,
possible webinar.
Yes. First of all, I would like to thank you for organizing this wonderful meeting. And for me, it was an amazing experience now to broadcast in India. And I thank Margrit Fisch for inviting me and to participate. It's a wonderful tool, and I look forward, if there's any chance, participate again.
We will love to have you again very soon.
It was amazing.
And Margit will see that you joined because we could only complete 50% of the slides of the PUV. So
we will see each other very soon, I guess.
Okay. Last comment, Professor Ansari and Professor Hemanth Pathak, please.
Yes, Doctor.
Very good discussion and very thoughtful. Everybody agreeing to disagree and reaching a common platform.
I just tell you all that Professor Hemanth Pathak is my mentor, who guided me in my initial period of having some interest in the academia. And so I'm really thankful to the Professor Hemanth Pathak. He always stay with me and guides me. Yes, Professor Ansari.
Dr. Anil,
my very dear friend.
Yes, not only friend, and you are also a great guide to me on many occasions also. And you have been a master of ceremony over the last 2 months. And you and Nitesh both have been striving very hard preparing all these slides for all of us. See what we do. We go through the slides, we read little bit, but the ultimately hard work is done by Dr. Anil and the Nitish. And
Yeah,
I really congratulate both of you for that.
yes.
Thank you. So Professor Margrit, just for your information, after our webinar, we did a 2 webinar where I didn't participate because we introduced other people also. So we had a one on Wilms tumor where master was Professor Ansari. We had another on a neurogenic bladder where the master was Professor Hemanth Pathak and again Professor Ansari. So with that we are trying to contribute and to your knowledge that if we do this kind of a session in bigger conference, we hardly get a audience of 40 or 50. Here probably we hit by this time almost 350 or 400 viewers. They were constantly online, and we have a more than almost 50 to 60 questions. We hardly get those things even in ESPU, EAU, or USI conference. So it's a great platform, and I thank you very much, all of you.
Final comment, Anil.
Yes.
The best thing I liked about today's webinar is the moderator and his efficiency.
Oh, thank you. Thank you.
That's a good statement. So bye-bye.
And see you soon again. Take care of you. God bless you.
Bye. Take care.
Thank you.
Thank you. Bye-bye.
Bye-bye.
Thanks, Anil. Thanks.